Welcome back, everybody. Welcome back to this Walk with the Doc, April 17th, 2019. Guys look great. You're all set for spring. We got the foliage coming out over there. The grass is getting greener every day, so great time to get out and walk. Today we have a terrific speaker. Many of you probably know Dr. Slade if you've had the chance of going to the emergency room. He's been an icon there in the emergency room for a number of years. But he's going to tell us a little bit about what to do if you go to the ER, and maybe more importantly, what to do to avoid going to the ER. You may have seen Dr. Slade at Cornerstone. He's an institution there as well. That's where typically I see him exercising. He comes from a very athletic family. His wife is a runner, and she's here today too. And the kids are as well. And medicine runs in the family, I guess, too. Okay. So, and he'll introduce himself in terms of his training. So, Dr. Slade.
Well, thank you all for having me here. Let me know if I need to talk louder or less loud. Sometimes I'm told I talk too loud, so I need to keep it down. But my name is Rob Slade. First, thank you all for having me. You know, I see those ads on Sunday morning for the Walk with the Doc, and every time I'm thinking, man, I hope I at some point get elevated enough that Jim Comezzo asked me to do it, and finally he got me. Maybe it was they couldn't find anybody else to do it, but I like to think it was the former, that I'm elevated to that level. But thank you all for having me. My name is Rob Slade. I'm an emergency physician at Doylestown. I've been at Doylestown for about 20 years. I've practiced emergency medicine for 32 years. It's been a great career, and I love the hospital and love being part of it. A little bit about emergency medicine, and it's funny how we'll still see people that come in and think that it's not, you know, they're not sure really who's taking care of them. Emergency medicine is a specialty. It's been a specialty since the 70s. At first, it was kind of a new specialty. At that time, when you went to a hospital, you might see an internist or a family doc, or maybe even a cardiologist was stuck for the day covering the ER, and they would come in and see you and maybe even go back to their office. And in the 70s, they started becoming a board-certified residency. So really started kicking off in the 80s, and now it's a very, very popular residency. It's a hard residency to get into. So especially, I mean, us older docs, maybe we weren't that smart. They would have taken anybody in my day. But now the younger ER docs are all, because it's so popular, it's also popular also correlates with hard to get into, like cardiology. And so it's they're all smart people. They're well trained. They know what they're doing. We have a full board certified emergency trained group. Most local hospitals would. So Abington would, Grandview would. You know, in suburban and urban areas, it will, for the most part, you will be seeing a board certified emergency physician for a physician. In some rural areas, you can't. There's just not quite enough. It might be a family doc. That's not to say they don't know what they're doing, but they may not be board certified. I used to be. Some people think residents. You're a resident. I guess I used to get asked that, but you know, not anymore. I don't get asked if I'm a resident anymore. But anyway, that's kind of the basics of emergency medicine. So what I wanted to do is Jim asked me to just give a basic talk on emergency medicine and kind of ways to smooth out your visit. So my topic's ways to make your ER visit smoother and ways to stay out of the ER. I do want to give a little credit to a Dr. Rhoda Jones. I got some of this information from her website. She had some cute little antidotes, so I wanted to throw kudos out to her. She's an emergency physician in New York. So I divided it into before, during, and after. So let's start with before you get to the ER, and these are some things that will make things smoother. Let's start with information technology. I think many people think now when you go to an ER, if you get any of your care anywhere else, we can click a button and we can pull up your records and we can see everything that you've had done at Penn and Temple and Jefferson and Abington, or if you're visiting from out of area, that we can just click a button and look at all that information. And that's the furthest from the truth for two big reasons. One, hospital ITs just don't interact with each other. They should. I mean, we have the universal technology to make this all happen, but it just doesn't. hospitals use different systems and they don't talk. So information technology makes it hard. And then the other part that makes it hard is HIPAA. HIPAA is the Patient Privacy Act that in many ways I think most medical people think we've gone too far on. It's meant, the act, like most laws, were meant to be positive to protect people, but in reality it's gone extreme, and places at times are afraid to give out information. You know, we're not asking for odd culture results on sexually transmitted diseases. We're asking for EKGs and blood work, things that shouldn't be that big a deal to get. But because of these privacy laws, other hospitals are very leery unless forms are signed and faxed over, and then they've got to go to medical records and pull up data, and that all takes time. And there are times where that 5 or 10 minutes of time really makes a difference in care. So some suggestions are for patients to keep their information themselves, and what I would suggest is an updated medical list. If you haven't, keep an updated medical list on you. You may say, oh, I always go to Doylestown, or I always go to Abington, or wherever you go, but you may say, I don't need it. They have it. But you know what? Unless you live in a bubble and never leave the 2-mile radius, you may be visiting family somewhere. You may be, going on vacation, and for them to get that information is hard. So keep an updated medical list. Keep an updated history, a basic medical history, surgical history, allergy history, and keep an updated list of doctors and phone numbers. I would ask all your physicians, what's the best number to reach you if somebody needs to contact you? And if you have that all on lists, I think nowadays if you have a smartphone, what I would do is make up the list and take a picture of it and keep it on my phone, and maybe even keep it on maybe a close family member. Have your list on their phone too, in case your phone is unavailable. If you don't use a smartphone, shrink it down as small as you can and keep it in your wallet or keep it in your purse. But medicines, history, old EKG is great. When I see a patient who has a cardiac history from out of town, and I get their EKG and it has some changes, I don't know if that's new or not. And having an old EKG can be life-saving to have that information. So all those things, again, I would keep it on a smartphone, but if you don't have a smartphone, even to keep it with you. So that's one thing to do before you ever come to the hospital. And again, doctors' phone numbers too are important. Something philosophically to think about is where you go. This is a tough one because I know people like their physicians in certain areas, but I think people should understand it's a lot easier to give good care when people are within the same network. Now, sometimes the care can't be within a certain network. Doylestown doesn't do neurosurgery, so you need a neurosurgeon from somewhere else. Or there's certain things that you need to go to tertiary places for. But understand, care is much smoother when there's continuity of care, and I would personally encourage people to, when you spread out your doctors to 3 or 4 different areas, it becomes more difficult to give care that way. Again, I'm not telling you to quit your doctor if you go somewhere else, but maybe if you've got a cardiac condition, things that you would need to go to the nearest ER for, it's not a bad idea to have a secondary one. Maybe say, could I also have this connection with somebody local where I'm going to go if I have that kind of emergency? And then finally, I just want to bring up urgent care versus ER. This has become a big thing the last 5 or 10 years, all these urgent cares that have popped up. They serve a wonderful purpose. They obviously they're cost conscious. Many times, I hate to admit it, but many times they're faster. And they do a great job with minor emergencies. So if, ankle sprains, cuts, minor infectious type things, they're great for. But if you've got abdominal pain, chest pain, the worst headache of your life, unusual dizziness, they don't have the resources to do all the testing, and you're going to just delay your care because you're going to go there and then they're going to transfer you or tell you to come over. I don't even know what happens with the bills, to tell you the honest to God truth. The billing becomes another complicated issue to go to one place and the next also. I personally, if I wasn't sure and I elected to go to an urgent care with my complaint, when I walked in the door, I would ask them, hey, look, if this is something you need to have me go to a hospital for. I'd rather just go now, unless you don't feel I'm stable enough to go. You know, so just think about the purpose that they do wonderful work. They are an important part of the system at this point. They're cost conscious, but I think nowadays, I'm guessing maybe because of time or co-payments, because the co-pays a lot of time are less at urgent cares. People are trying to push diseases to go to urgent care that probably don't belong there. So those are all things ahead of time just to think about. I think the most important is having records. I think that's really very, very important. During your ER stay, understand when we walk in the room to see you, you should be and are the most important person to us. And in the ideal world, you would be the only patient we see. You know, I'd have one patient, and I'd come home and say, I saw one patient today, and that patient was the only one, and I put 100% of my effort into that patient. But the reality is we have 6, 8, 10, 12 patients. We're getting calls from physicians. Nursing are calling us. We're getting yelled to go out of the room and see somebody else that has another emergency. So it's very important to be concise in your history. The best you can, you know, give your story. Start from the present. We want to know what brought you in now. And in fact, the nurses bust my chops because I have this little thing where I'll slap the back of my hand and say, what happened now to make you go to the ER? And I have to admit, at 3 o'clock in the morning when I'm tired, I might be saying that a little sarcastically, but the reality is it's true. We need to know what happened now for whatever your complaint is. If you've had abdominal pain 4 days, but something changed now to make you come now, and it's important to know that. And it's important to be honest about it. If it's because the pain got worse, or it radiated somewhere, or you developed a fever, those are all important things. It's also important to be honest if it was something like I Googled it. I looked it up online and I got nervous about it, or my brother-in-law's a physician and he told me I should get it checked. We're honest answers are much better and help us do the correct workups. Along the same lines is, I'll just mention this. You know, when people come to an ER, it's not uncommon for them to have called their doctor and the doctor say, you know, go to the ER, which is appropriate. But it's not a restaurant, and I know sometimes people get upset if they're not seen right away, but the reality is people are brought back based on their acuity, not on when somebody calls in. So we try to get it, ideally everybody would come back right away and everybody would get seen right away, but that's not reality. So we love when physicians call in, especially if it's to give medical information, but understand, just because you've called in doesn't mean you're going to get seen any sooner. It just isn't the way the system works. As far as family in room, to me, ideal is 1 or 2 family member. I just understand it's not a social visit. It's an emergency department. When people start having 5, 6 people in the room, it complicates things. The rooms are nice size rooms, but they're not massive. As far as communicating information to family, it becomes more complicated. To me, the ideal is 1 or 2, a significant other or spouse or child or an adult, and maybe 1 other person, especially if it from a hearing communication. I think it's kind of nice for 2 people to hear, because sometimes when you're getting thrown with a lot of information, you don't always hear everything. I also think it's great when there's kind of a family spokesman if somebody's really sick to explain the same story to 3 or 4 different family members becomes hard and time consuming, and I think it's great if there's like a single family spokesman that can kind of be the person designated. I did forget one more thing on before, although I think they're going to address this last week, and this would also be done ahead of time, is discussions on end of life, time of, how you would want to be cared for when something bad happens. I think it's important for everybody, once you're an adult, I don't care what age you are, to be very comfortable with how you want your care if something life-threatening happens. I know they're hard discussions, but it's very, very important, and to have that discussion in the ER when we've got sometimes minutes to decide whether to put somebody on a ventilator or not, or whether to do CPR CPR and pump on their chest, it's not the ideal time to do that. They're very hard decisions. I don't think families should feel like they're making the decisions on their family member's life. The decision really is being made by your medical issue, not by you. But I think it's important for families to know what each other wants in case something life-threatening does happen. So that's also in the before category. And finally, after, emergency physicians, I hope and I think we're expert at acute first opinions, but we are not experts at second opinions. So the ER is not the place to say, well, I've been to multiple docs and they can't figure out what's going on, and so I decided to come here. The reality is we're probably not going to figure it out either. If you've got some rash you've had for 6 months and you've seen your primary and you've seen your dermatologist and you've seen an infectious disease doc, the reality is we're kind of designed to decide whether something is an emergency or not. And so just remember, we're, I hope, great at first opinions, but we're not great at second opinions. And that's why it's also important, just because we send somebody home from the ER doesn't mean that there's not something going on. There very likely is something going on. But with the testing and our opinion, we just don't feel that it's something that requires hospitalization. So don't leave the ER thinking, well, everything's fine, this is nothing serious, or this doesn't need follow-up. Vast majority of people do need follow-up. And again, it doesn't mean there isn't a medical issue that needs further addressing. It just means you don't need to stay in the hospital for it. So those are all kind of the basic ER. So now ways to avoid the ER. Any questions so far? Feel free if anybody. If somebody came in all by themselves and the hard part is all of these directives are very vague, and many of them talk about if it's a terminal illness, and it's hard to define what's a terminal illness. What you can and come back from. I think if somebody was alone and they had their advanced directives was clearly is part of the system, and that is in the system at Doylestown Hospital, then we would absolutely take that into consideration. I mean, if a healthy person came in that was in a not that we don't typically see major trauma, but if a healthy person came in and it was a major accident, we wouldn't not treat them just because they have an advanced directives, but if somebody with terminal cancer and was on hospice and they called and they had an advanced directive and they were the only one, then that might be enough to have us not be aggressive and keep them comfortable. But family really supersedes anything in writing, because people will say, and they change their mind, they this or that. So the people that are there really supersede anything in writing. So ways to avoid the ER: exercise. This is probably the group we don't need to say this to, but to me, exercise just has so many values besides the obvious of cardiovascular and staying in shape and weight control and all that. Emotionally, it's a huge plus. It's obviously a social network too. So exercise, I can't stress enough how important exercise is. Avoid ladders. Especially if you use a walker or a cane. If you use a walker or a cane, you shouldn't be on a ladder. Even if you don't use a walker and a cane, I still encourage avoiding ladders. I have one. I use it. I shake like a leaf going up it. So I'm, obviously say that a little jokingly, but be very, very careful on ladders. And if you have any balance issues at all, don't clean your gutters. Don't go, more than a couple feet off a ladder. Drink in moderation. Actually do everything in moderation. I'm a firm believer in moderation. Personally, I think even if you've got diabetes, an occasional piece of cake's not going to kill you. Do you need to eat a whole cake every other day? No. Is an occasional glass of wine or beer okay? Sure. Is a 6-pack or 2 bottles of wine a day good? No. So everything in moderation, and obviously don't drink and drive. That's a no-brainer. Avoid trampolines. Every time I drive by a house that has a trampoline, I think, well, that's business for us, because they're terrible. And if you have one, if your kids have one for their kids, I would never have one. Somebody's going to fall and break their wrist. Somebody's going to get a neck injury. Something's going to happen with a trampoline. Avoid trampolines and motorcycles. Obviously avoid drugs and cigarettes, and do anything you can to get off them. That's great. And weight control, obviously, exercise, weight control. You want to do the best you can to get off not just drugs but medications. Now, I say that I'm not saying you shouldn't take your meds. Obviously, you should take all your meds. But the best thing to do is, if you're say a little overweight and you don't exercise, the best way to get off, metformin and one of the statins and the blood pressure meds is to exercise and get in shape. Vaccinate your kids and get a flu shot. Everybody, if anybody that wants to listen to Jenny McCarthy, when you get sick, go see how she manages your medical care. She's the anti-vaccine person, and obviously the recent measles outbreak is a great example of unfortunately some groups, for whatever reason, not listening to medical science. Are they perfect? No, of course nothing's perfect, but they're very, very good, and all the vaccines have saved millions of lives. Don't text and drive. I have to admit, I have to be careful about that myself, but put the damn phone down, and don't text and drive. Socialize. Now, again, I'm preaching to the choir here, but socialize has been shown to decrease dementia, decrease depression, and there's even some data that it helps people live longer. So socialize, and part of that's also volunteering. So get involved in things. All of that makes for a better life and actually makes for a longer life. No better volunteering than the one over at the hospital. The hospital volunteer programs just amazed me when I came here 20 years ago, and it still amazes me. Put away your meds and get rid of old ones. That also goes for any batteries, especially button batteries. If anybody has little kids or grandkids, I think the best group of people to open up a child-proof cap is a kid. And I don't know how many times in the ER we see a kid that's taken an overdose, and it's typically, the typical stories, it's the grandparents' med that they got into, and they took their lisinopril or they took their metoprolol or their metformin and took some of their pills. So put your meds away, get rid of the old meds. Button batteries are horrible. Like hearing aid batteries, button batteries, make sure if you have family around, especially little kids, make sure that they're all put away. Of course, take your meds. When I talked about getting off meds, that's all through exercise and lifestyle, but take your meds. Don't take anybody else's meds, even if they're the same color. Doesn't matter. You're not supposed to take other people's medications. Avoid Google. Avoid Google. It does get us extra ER visits, but if you've got an issue, Google's not the place. I joke, I keep waiting for this cup, but I saw a cup once that said, don't confuse your Google search with my medical degree. But I kind of laughed at it, but it's kind of true. You're just going to get yourself upset, and if you have a medical question, ask the right medical person. Don't store things in bottles they don't belong. This kind of goes along with the med thing. If you've got anything at home that you've got some kind of paint thinner, you've gasoline, something, don't pour it in a Pepsi bottle and store it on the shelf. These are all things we see in the ER. Somebody, typically that kind of thing, it's a little kid or somebody doesn't realize what it is. Get a doc. If you don't have a regular doc, get a regular primary physician. They're better at diabetes and hypertension management than we are in the ER. That's not our shtick. Get a regular doc and get a dentist. By the same token, mouth and oral care is very important for long-term prevention. And then the final one is call 911. If you ever have an issue, don't be shy about it. That's what it's there for. You know, when people have indigestion or vague discomfort, it's not your job to diagnose yourself, and the reality is that it's not unusual for us to be fooled. The point being, the history can be very hard, and so you shouldn't be expected to decide whether it's an emergency or not. If you're at all concerned, don't be shy about calling 911. So that's my little shtick. Any questions?
What would be one of your most rewarding things you do as an ER doc? On a day-to-day basis, you come home 3 in the morning, it's been a long shift. What are some of the most rewarding things?
I think the most rewarding thing for me, I mean, you always feel rewarded when you make like an unusual diagnosis or something you're not expecting, and you have an occasional case. I had a gentleman with a thoracic aneurysm that I was very proud of picking up. You know, most of it you're used to doing, and that's what you do. So you kind of feel expected. I think the most rewarding thing for me is really just the interaction with people. I love talk, you know, if you have the time, and time's always a factor, but I love spending time talking to people in the room if I have the time. I love hopefully trying to care for people the way that I would. So I think it's really just the interaction with people and families is probably the most rewarding part.
Well, thanks for your time.
Sure.
Appreciate it.